The broadcast is now starting. All attendees are in listen-only mode.
Hello everybody, my name is Cheryl Fatibeni. I'm the Chief Nurse Practitioner Officer at the NNCC, and on behalf of the National Nurse-Led Care Consortium and the AANP, I would like to welcome you to today's Lunch and Learn webinar, Acute Pain Management in the Opioid Tolerant Patient. Our presenters today are Kathleen Broglio and Maureen Cooney, both doctorally prepared nurse practitioners who work in pain management. Today's webinar is being recorded and will be available in the upcoming week on our NP-SAN portal page, and a link to the recording will be sent to all registrants. All participants will be muted throughout the presentation. I encourage you to submit questions during the presentation. Please use the Questions tab on your GoToWebinar control panel as seen here to ask your questions. It will be relayed to the presenters and answered at the end of the webinar. A survey will pop up at the end of the webinar and will be sent in an email later today. Please take a few moments to complete the survey evaluating this activity, as your feedback is critical to the ongoing development and presentation of our webinars. The slides for today's webinar are available as a handout, which you can access via the Handouts pane in your control panel as seen here. You can click the name of the handout and it will be downloaded via your default web browser. I'm going to turn it over to my colleague Joseph at the AANP to tell you how you can receive CE credit for today's presentation.
Hello everyone, this is Joseph with the American Association of Nurse Practitioners. Today's webinar is accredited for continuing education credit by AANP. There are a couple of qualifications in order to receive CE credit today. First and foremost, participants who are viewing today's webinar must participate in at least 55 minutes of today's presentation to qualify for continuing education credit through AANP. In addition to that, participants are required to view the presentation in real time. So phone-in only participants do not qualify for CE credit today. So if you did phone in only, go ahead and disconnect from your call and join the webinar so that you can view the webinar presentation in real time. You should have received a confirmation link for the webinar, and if you click on that link, you'll be able to join the webinar and view the presentation slide deck in real time, and then that will help you qualify for CE credit, assuming you attend 55 minutes of the presentation. So after the webinar is complete, I'm going to vet the entire list of participants through our webinar platform, and those who have met the qualifications will receive an email from me specifically stating the detailed instructions for obtaining CE credit on our AANP CE Center. As part of that process, you're going to receive a passcode, a very specific passcode, and you'll be required to complete an evaluation on the AANP CE Center in order to receive your CE credits. If you have questions in the meantime, you can direct them to me at jreyes@aanp.org.
Thank you, Joseph. So I wanted to take a quick moment to talk about the national investment taking place for quality improvement in the U.S. with the help of our federal government and the organizations who are presenting this content as part of the Transforming Clinical Practice Initiative, which is sponsoring today's presentation. The Transforming Clinical Practice Initiative, or TCPI, is CMS's largest ever investment in practice transformation, with an investment of over $700 million over 4 years and an enrollment of 150,000 plus providers across the country. The NNCC, our organization, or the National Nurse-Led Care Consortium, is a membership organization with over 250 nurse-led practices on our membership roster. Our mission is to advance nurse-led care through policy, consultation, and programming to reduce health disparities and to meet people's primary care and wellness needs. Our partner in this initiative, the American Association of Nurse Practitioners, is the largest full-service national professional membership organization for NPs of all specialties. It is leading the way in advocacy, continuing education, and professional development for over 79,000 members and growing. CMS funded the NNCC and the AANP to support enrollment of nurse practitioners into practice transformation networks, or PTNs, across the country, and to develop NP-specific educational materials that facilitate practice transformation in advance of upcoming payment reform changes with CMS. The NNCC and the AANP are the only nursing-focused grantee of the TCPI project. The NNCC and AANP agree that this initiative is important to ensure that nurse practitioners receive the support they need to remain competitive in a changing healthcare landscape. NPs are the future of primary care in the United States and already provide high quality and cost-effective care. This initiative is an opportunity for NPs to prove that by helping CMS and the broader healthcare community build the evidence based on practice transformation while preparing for a value-based reimbursement environment. So how do we prepare NPs and all other clinicians for upcoming value-based reimbursement? We want to use this program to prepare clinicians across the country for payment reform under MACRA, the Medicare Access and CHIP Reauthorization Act of 2015. Many of you have probably heard of MACRA. It's legislation that was passed to establish Medicare's Quality Payment Program, or the QPP. Under the Quality Payment Program, there are two payment adjustment mechanisms to incentivize quality tied to Medicare Part B payments: MIPS, or Merit-Based Incentive Plans, as well as advanced APMs, or Advanced Alternative Payment Models. Most clinicians will end up associated with MIPS, or the Merit-Based Incentive Plans. MIPS involves 4 elements that clinicians need to demonstrate successfully to maximize their Medicare Part B payments. These elements are that of quality, resource use, identifying clinical practice or CQI activities that they are engaged in their practices, as well as the effective use of health IT. If you can demonstrate these 4 elements in your practice, you can succeed in a value-based payment environment. At this point, I'd like to turn our presentation over to Kathleen Broglio and Maureen Cooney.
Hello. Well, welcome to this webinar, and we're really excited about talking with you about acute pain management in the opioid tolerant patient. I'm a nurse practitioner at Dartmouth Hitchcock Medical Center. I'm currently doing palliative care, where probably 75% of my practice is with pain management, and probably 50% of that is with people who have substance use disorder or at high risk for substance use disorder. And my past background has been in the acute and chronic pain management world. And my colleague Maureen.
Hi, I'm Maureen Cooney, and I'm very happy also to be able to join you today. I'm a pain management nurse practitioner at a large medical center in Valhalla, New York, where I do primarily inpatient pain management and on a daily basis manage patients who have opioid tolerance. And I know that this is a situation that most of us are handling these days, whether it be prescribed opioids or whether it be opioids use that would be part of substance use disorder. So I'm going to turn it over to Kathleen and let her get us started at the beginning of the presentation.
And just so people know, this came about, Maureen and I worked together in New York City at different organizations, and we presented this material at a national conference about a year and a half ago and decided that we should turn it into an article, which we did for the Journal of Nurse Practitioners back in June of this year, and then it turned into, or maybe March of this year, but then it turned into this presentation. So let's move on to the next slide with the objectives, where we hope today that the challenge you probably already know, so we're going to review that very quickly. And Maureen's really going to outline what are we doing with multimodal analgesia to treat acute pain. And I'll talk a little bit more about what are the strategies we use to improve pain management for that patient who's opioid tolerant. So in the next slide, we'll see, what is the problem. I think we don't have to put out to you what's going on. You hear it in the news every day, but we have to remember that 1 in 10 Americans has used an illicit drug in the previous month, and that the non-medical use of opioid pain relievers was only second to marijuana as the most commonly used drug. And the overdose deaths are continuing to rise, and not only from prescription opioids, but from the illicit fentanyl and a rise in heroin use. So more and more we're going to be encountering people in the medical system that may have opioid tolerance secondary to prescription drug use, but also secondary to these illicit drugs. On the next slide, we're going to talk a little bit about opioid use disorder. So more than 2 million people sought treatment for opioid or substance use disorder. So substance use disorder is a larger platform of which opioid use disorder is one of them. And about 300,000 people received methadone and 32,000 people were on medication-assisted treatment with buprenorphine. Now these numbers are from 2011. We think that the number of people that are going to be treated with buprenorphine for medication-assisted treatment is going to rise because of the Comprehensive Recovery Act that now allows us as nurse practitioners to actually prescribe buprenorphine in the office setting, and probably some of you who are listening into the call are doing that at this time. And so when we think about acute pain management, what are some of the challenges and the clinical significance? There's not a whole lot of studies, but some of the studies on the next slide that you'll see will look at that. We know that chronic pain may be more prevalent and really may predate the onset of opioid use disorder. And this is what has happened as a result of the broadening use of opioids for chronic pain with our potentially good intentions to treat pain with opioids without realizing the consequences of increased risk for opioid use disorder. In 2 studies on elective orthopedic surgical population, they saw that those that had opioid dependence or abuse had higher morbidity, mortality, and resource utilization. And in another study that looked at people preoperatively for spine surgery, though comparing those that had been on opioids prior to surgery versus not, those that had been on opioids chronically preoperatively had less favorable outcomes, not only in terms of pain afterwards, but disability and just mental and physical functioning. And in a more recent study that looked at patients that were hospitalized that were on chronic opioid therapy, there was seen a higher amount of class C. diff and hospital-acquired pneumonia. So now I'm going to turn it over to Maureen, who's going to present the case and talk a little bit about acute pain.
Okay, so before I even get into this case, I just want to mention that certainly patients who are opioid tolerant may be our patients who we are actually prescribing opioids for, as well as those patients who suffer from opioid use disorder. So a definition of opioid tolerance by the FDA would be a patient who is taking the equivalent of 60 milligrams of oral morphine a day for a week or more. So many of you may have those patients in your practice, as well as those patients who are using opioids not through prescriptive ways. So the case that I'm going to be talking about really is a case that highlights many of the issues we deal with, whether there are patients who are experiencing opioid use disorder or they have prescribed opioids. We're going to be talking about very similar kinds of issues. So this was kind of an extreme situation. It was a 44-year-old gentleman who was admitted to an acute care setting after a motor vehicle accident and had a traumatic amputation of his leg, which required an emergency for a surgical repair. In the OR, his pain was very, very difficult to control. They had given him 700 micrograms of fentanyl, as well as additional fentanyl boluses as he was coming out of the OR. And in addition to that, he received 2 milligrams of hydromorphone IV and was given ketorolac. In the PACU, his pain was really difficult to control. He required bolus after bolus of morphine, up to 16 milligrams, an additional 6 milligrams of IV hydromorphone, and midazolam, 2 milligrams, were given in the PACU. So clearly this was a gentleman who was having a lot of pain, but also had opioid tolerance as well. A urine toxicology that was done in the emergency department as he came through showed that he was positive for opioids. He was also positive for benzodiazepines, cocaine, and marijuana. So again, no surprise, we see this so often that our patients have polysubstance abuse. So where did we go from here with him? Well, first I'm going to get into some generals and I'll tie up the case later on. So in any patient coming in whom you're trying to get pain under control, of course you're going to do a comprehensive assessment of that patient. And you're going to do a comprehensive pain assessment as well. On the slide here, I just included the term WILDSA that some people use as far as an acronym to remember what to ask as far as pain was concerned. So the W is words to describe the pain, I for intensity, L for location, D for duration, and A for what alleviates or what aggravates the pain. You need to determine, are we dealing with a patient who has acute pain, or is it someone who has chronic pain, or do we have acute on chronic pain? And in this individual, and in many of our acute pain patients, they certainly do have chronic pain as well. It's also important as part of your pain assessment to determine what type of pain are we dealing with. Nociceptive or normal pain that you would expect, neuropathic or pain resulting from damage to the nerves, as this gentleman had, or a mixed type of pain presentation. We also need to assess for what type of analgesics this individual has been exposed to. What have they used in the past? What works? What doesn't work? What analgesics have been prescribed, and what are they using that's not prescribed? It's really important to set a climate of being very open so that you can elicit the necessary information that you need, because you need to be able to get a sense of what this person's tolerance is. So I will tell you with this gentleman here, he did tell us that he was in methadone maintenance therapy, and he, in methadone maintenance treatment, was receiving 130 milligrams of methadone a day. So from there, it was a question of, okay, well, what else is going on? I also found out that he had been using heroin actively, a bundle to a bundle and a half of heroin a day. So for those of you that may not be familiar, that's somewhere in the range of 10 to 15 bags of heroin a day. He was also using alprazolam on the outside, not prescribed, 10 to 12 milligrams a day, and he was using marijuana daily. And one of the big questions I had for him was, if you're actively using heroin, why in the methadone maintenance treatment program aren't they bumping up your methadone? Because clearly the methadone isn't enough to keep you from craving and using the heroin. And the answer was because his alprazolam addiction had not yet been addressed. And the methadone treatment program was afraid of giving him more methadone while he was still abusing alprazolam, because they were afraid of the potential for death as a result of the combination of the benzo along with the opioid. So it really required some digging to come up with that information, but it made it quite challenging. So certainly we need to be assessing for comorbidities. Do your patients experience depression, which is very common with chronic pain and certainly with substance use disorders? Do they suffer from anxiety? Do they have insomnia? And the other thing that's really important in trying to address these patients is to assess for any opioid withdrawal. So we use a particular tool called the Clinical Opioid Withdrawal Scale, which just really summarizes some of the common withdrawal symptoms that you might see, like pupil dilation and the yawning and the aching and the nausea, vomiting, and the diarrhea. But I would suggest that you use some kind of a tool to assess your patient for opioid withdrawal, and of course assessing for polysubstance use, as this gentleman had, and the associated withdrawal risks from those other substances. So of course we're all aware that benzo withdrawal and alcohol withdrawal can be deadly, and we'd want to know about that up front so that we could be preemptive and prevent that withdrawal. Next slide. Thank you. So what do we do with this gentleman? Well, first and foremost, for any of these patients who have opioid tolerance, the acute pain interval of time is not the appropriate time to stop opioids. It's not a time to try to detox them. It's not the time to try to rehabilitate them. We as nurse practitioners want to do the right thing for our patients, and our tendency is to want to fix it all in the moment. But we have to be patient and realize that this is not the time to try to get rid of the opioids. Clearly, the opioids are still going to be required to certainly prevent withdrawal. But the best way to manage pain for that person with acute pain who is tolerant is the use of multimodal analgesia. And just what it is the use of a variety of analgesic agents, as well as perioperative interventions and non-pharmacal modalities. And the reason that we're bringing all of these different interventions into play is that we know with multimodal analgesia, the combinations of using different analgesics from different classes of agents will act on these different target sites in the pain pathway. And as a result, we'll be able to get better pain relief and at the same time reduce the overall amount of opioid that's required, and therefore reduce the amount of side effects, or reduce certainly some very significant side effects. Next slide, please. So here's the rationale for the use of multimodal analgesia. So we'll take it from the bottom there where you see the star indicating the trauma that has occurred. At the site of injury, we're going to see the release of pro-inflammatory mediators in response to tissue damage. And from there, you're going to get a signal sent by way of the afferent nerves from the site of injury to the dorsal root ganglia over to the dorsal horn. And at the dorsal horn, the pain signal is going to travel up the ascending fibers to the brain where pain will be perceived. And our bodies have this fascinating way to be able to try to cool off or modulate that pain signal. So what you see coming down from the brain is the blue arrow indicating modulation, which primarily occurs as a dorsal horn, where we're able to block or modulate some of those pain signals. So having the awareness of the pain pathways, we've then been able to develop ways to be able to intervene along the pain pathway to reduce pain. So at the site of injury, medications like your anti-inflammatories, your NSAIDs or your COX-2 inhibitors, your local anesthetics, and your gabapentinoids will be effective out there in the periphery. And we also know that there are some opioid receptors out there in the periphery that might be optimized or might be utilized. Along those afferent nerves, the peripheral nerves, local anesthetics are going to be helpful. At the dorsal horn, that's where opioid mu receptors are going to be located that will help with your pain. Alpha-2 agonists like Clonidine, like Dexmedetomidine, will be working along that site. Local anesthetics, anticonvulsants, and your gabapentinoids will be able to exert an effect there. And then at the level of the brain, medications like acetaminophen, the alpha-2 agonists, NMDA antagonists like ketamine, and your opioids will certainly have receptor sites in the brain. So that will, every one of those locations is an opportunity to put up a wall or a boundary to prevent that pain signal from making its way ultimately to the to the brain. And then as far as the modulating pathways or the descending pathways to cool off the pain signals, we have the opportunity to use medications like the anticonvulsants and the antidepressants to be able to cool off the pain. The non-pharmacological approaches like biofeedback, like distraction and imagery also work on that modulating pathway coming down from the brain back down to the dorsal horn. Next slide, please. So the American Pain Society in 2016 published guidelines for us to be able to help us in the management of acute pain. And these guidelines really are based upon a multimodal approach. And one of their main points is that we should be utilizing acetaminophen as well as NSAIDs, if possible, as part of a multimodal analgesic plan, of course, unless they're contraindicated. What they found with this routine use, scheduled use of acetaminophen and NSAIDs is that our patients have less pain and their opioid consumption drops. The combination is more effective than using either agent alone. And when I speak about this, I think this is something that people who have no medical background actually do even with their children when they go in to get immunizations. They instinctively know to give that acetaminophen every 6 hours and give the ibuprofen every 6 hours opposite each other to keep their children comfortable. So this is a practice that we really should be embracing clinically. And the other point that I like to make is that we really need to be sure that these medications are scheduled if they're safe for your patient. And the reason for that is that when you leave them as a PRN order, very often they don't get given. If you leave PRN acetaminophen, PRN NSAID, and a PRN opioid, and you go back and you look at the medication administration record over and over again, you'll see that it's the opioid that gets administered. Another intervention that they recommend is that we use celecoxib if the NSAID is not appropriate. So very often we'll use ketorolac for the first 5 days, and once the patient is taking a medication PO, we may switch them over to celecoxib, and they recommend 200 to 400, can be given preoperatively, then followed by your daily dosing. Next slide, please. They also recommend the use of gabapentin or pregabalin as part of multimodal analgesia. So these medications can be started preoperatively With gabapentin, you see here 600 to 1200 milligrams pre-op, or 150 to 300 of pregabalin, 1 to 2 hours preoperatively. And then postoperatively, they would be continued with gabapentin or with pregabalin to manage their pain using a multimodal approach. Next slide, please. Clonidine and Dexmedetomidine are also helpful in a multimodal analgesic plan. Both of these agents act centrally, as I showed you back on the pain pathway, and they also act peripherally by acting on the alpha-2 adrenergic sites. They are very helpful with sympathetically mediated pain, meaning that it's coming through the cord. They're also helpful with patients who have headaches and various neuropathic pains, as well as different kinds of spinal cord injuries. So they are just agents to keep in mind that can be very helpful for that central type of pain. And the other important piece with clonidine in a patient who has substance use disorder is that they will also help to reduce some of the withdrawal symptoms. Next slide. Another agent that we use quite a bit, and many of you may be using now as more and more attention is being paid to it, is ketamine. Ketamine is an NMDA antagonist, so it blocks that receptor site. And in blocking that receptor site, it helps to reduce that pain signal, which is induced by the glutamate. NMDA receptor antagonism has been shown to reduce opioid requirements. Ketamine is highly lipid soluble. The beauty of it is that it is respiratory preserving. It does not normally affect respiratory status, does not cause hypotension, and the analgesia that's provided is double that of morphine. So we find this to be a really good agent for our patients who are opioid tolerant, because as in the case of a gentleman like this, it would be very, very difficult to manage his pain with opioid alone. It would require tremendous doses of opioids to be able to get his pain anywhere near under control. So ketamine allows us to attack that pain using a totally different pain receptor site, and yet it's a very, very potent analgesic of and by itself. Many of you are familiar with it because it's used often as an anesthetic agent, but for pain management, the dosing is lower. It usually is in the range of 3 to 7 mics per kilo per minute that you would use and titrate to get appropriate pain management. IV administration has a rapid onset in about 30 seconds, peaks in a minute, and if you're only doing single shots, it's only going to last for about 60 minutes, or with a half-life of 2 to 3 hours. But many of us use this as a continuous infusion until that patient's pain is better controlled. Next slide. Another intervention that's recommended by the APS and many of us are using in an attempt to be able to use non-opioid therapies or reduce opioids is the use of intravenous lidocaine. IV lidocaine has been found to have anti-inflammatory properties as well as the analgesic properties that we're quite aware of and anti-hyperalgesic properties. Many patients with opioid tolerance are hyperalgesic, and IV lidocaine can be very helpful for that. It is an NMDA antagonist as well by blocking that glutamate and blocking sodium channels, and it's been found to be particularly helpful after abdominal surgeries. So it's been found to reduce post-op pain and also reduce those opioid requirements. And the beauty of medications like ketamine as well as lidocaine is that they also help in terms of GI function. They are not going to create problems with constipation and ileus, and therefore can help to reduce your length of stay as well as nausea and vomiting. Next slide, please. Kathleen?
So let's talk about some special challenges. And on the next slide, you're going to see a chart that's more for your reference, that talks about 3 of the medications, the only 3 ones that we use at this point for medication-assisted treatment, and that you'll have patients that will come in on either of these medications. And just a few key points. When we think about methadone, it's a full mu opioid agonist, and so it's given once a day for opioid use disorder, but we also use it in pain management. The difference is that when we're using it for pain, it only has an analgesic effect between 6 and 12 hours. And so sometimes you'll talk with people and they'll say, well, I don't understand why we just can't use this for pain because they're on this huge dose of methadone. Well, yes, it will help for maybe 6 hours. Buprenorphine, naloxone, or buprenorphine alone, which is a partial mu agonist. And so what this is doing is it's actually occupying the mu receptors and reducing craving. The naloxone is only in there to prevent abuse, meaning that if someone takes the naloxone, melts it down, and injects it, with the buprenorphine, it will block the effect of the buprenorphine. That's the main reason that we're using the naloxone. So buprenorphine in itself will provide pain management, but only to a certain point. The beauty of buprenorphine is that there's less chance for overdose because it is a partial mu agonist. But being a partial mu agonist is where it's going to cause some challenges when your patient comes in on it. The final one is naltrexone, which is a full mu receptor agonist that's either used orally, daily, or intramuscularly once monthly. And this is going to be your biggest challenge when someone comes in if they're having it intramuscularly once a month, because it's going to block your mu opioid receptors. Now, on the next slide, we're going to talk a little bit about what happens when that patient comes in who has active opioid use disorder. This is my patient that shows up 2 months ago and tells me that he shoots up carfentanil, which is the illicit fentanyl on the street now that's about 100 times more potent than the fentanyl that we use, and he's doing that 3 times a day. There's no way that I'm going to know what dose to even start on. And so, as Maureen pointed out, we need to use multimodal therapy. And we need to be able to use opioid therapy because we don't want to cause withdrawal. And this is where we might use a patient-controlled analgesia because we don't know what this person is going to require. And if we do put the person on opioids, like say oral, it's better to do it scheduled versus as needed. It's scheduled like, Q4 hours, may refuse, hold if sedated, because then that takes the anxiety off of the clinicians taking care of them who may be prone to judging, like, oh my goodness, this person's clock watching at 3 hours and 45 minutes, they're asking for their every 4 hours needed med. This is where we're going to want to use clonidine to prevent withdrawal symptoms and potentially anxiolytics. But remember, respiratory depression still can happen even in someone who's opioid tolerant, and especially when we don't know what they're using. So we're going to really need to use close monitoring. And this is the person that we're going to want to try to wean off of opioids prior to discharge, and if possible, refer to medication-assisted treatment, or in some cases, we may actually start medication-assisted treatment with methadone or buprenorphine in the hospital if we know that there's a transition that we can move to. So on the next slide, we'll see what happens when we have someone who comes in that's on medication-assisted treatment. The first thing we need to do is verify what they're on. With the opioid treatment program, we're going to verify what dose of methadone they're on. For the buprenorphine or naltrexone, they may be going to a private clinician's office or a health center. So you're going to have to try to be able to verify with that. What happens if it's a weekend and the opioid treatment program is closed and that person tells you they're on methadone 200 milligrams a day? Most facilities will have some type of institutional guidelines. In general, it says that we should not be using more than 40 milligrams a day, but this would at least help prevent that person from going through withdrawal. In all of these cases, we're going to use multimodal analgesia, and we're going to have to realize that we're going to have to supplement with IV patient-controlled analgesia or immediate release opioids at much higher doses than we usually anticipate. And again, scheduling doses rather than PRN is probably better to decrease the stress both on the patient's part and the nurse taking care of them. On the next slide, we'll see what happens when someone's on methadone maintenance. We should always be continuing with their daily dose of methadone unless there's a reason, like does that person have increased somnolence? I've taken care of people that were on methadone maintenance. They were on take-home doses because they had been stable, and what I didn't know is that they were basically selling it. So they come in the hospital, we put them on their scheduled dose of methadone, and they become over-sedated. You want to supplement with immediate release opioids if they're not able to take oral use the PCA. And again, you're going to need to monitor for respiratory depression. If the person is NPO and you do not have IV methadone in your hospital and you don't have an NG tube, then you're really going to be challenged to try to provide opioids via an IV PCA, probably at much higher doses, especially if they're not getting their methadone for methadone maintenance during this time, because that methadone, even though it's used for maintenance, will still provide some pain relief. Next slide. When that person is on buprenorphine, there's a number of different strategies that people have come up with on how to handle this, because remember, what's going to happen is, because it's a partial mu agonist, and then if you put acute pain over it, now you may get some pain management from the buprenorphine, but if you try to override the buprenorphine with a full mu agonist opioid, you must use much higher doses to do so. So you would always want to use multimodal analgesia, like Maureen pointed out. And this is where, like, if that person has continued on buprenorphine, you would treat the acute pain with things like fentanyl, hydromorphone, in sublingual or intravenous buprenorphine if available. Next slide. So what are the ways to do it? Some people recommend continuing the buprenorphine, and you could actually give it in divided daily doses because it will provide some pain management. Other people say discontinue the buprenorphine, especially if it was a planned admission, but you're going to anticipate it's going to take 72 hours to clear the system, and so you're going to have to use much higher doses of your mu agonist opioids, because remember, at 24 milligrams a day of buprenorphine, you've occupied about 96% of the mu opioid receptors, and so to try to overcome that. And that's why we're going to have to consider a monitored setting, because after that 72 hours, and once the buprenorphine has cleared the system, you may need much lower doses of opioids. And someone I'm working with who helps monitor these programs, because I also do buprenorphine in my clinic, really some of the newer recommendations that are coming out are saying continue the buprenorphine, because if you don't continue the buprenorphine and you wean them off, if that pain resolves, then you're going to have to wean them off the opioids, put them in some withdrawal to restart the buprenorphine. And are you in that period where that person's not on opioids or not on buprenorphine, that they're at higher risk for relapse? Next slide. So naltrexone, oh, back one, please. No, you're going forward. Okay. Naltrexone. So naltrexone, if they're on oral naltrexone, you want to discontinue it 72 hours prior to surgery, because remember, it's fully blocking the mu opioid receptors. Obviously, if it's a planned surgery, you want to discontinue the intramuscular naltrexone 1 month prior to surgery. But what happens if that person comes in, they've had a trauma, and they've had IM naltrexone? Obviously, you're going to use your multimodal analgesia. This is where you're going to really hope that you're able to use regional anesthesia. But if you have to use opioids, you may need to use 10 to 20 times the usual dose to try to overcome the naltrexone blockade. And this can be really challenging. Back before it was actually approved for use, I had someone I was caring for, and no one knew what was going on. He kept saying, no, I'm getting something from my doctor, and it's experimental. No matter what we were giving them opioid-wise, it wasn't working. Well, it ended up he was on naltrexone. So, you know, the 2 milligrams, 4 milligrams, 8 milligrams, 10 milligrams of morphine, we're not going to even touch that. You must remember that if any of these cases, whether it's methadone, whether it's buprenorphine, whether it's naltrexone, whether it's someone with active opioid use disorder, the biggest risk is that they are at increased risk for overdose if once discharged from the hospital they relapse because of some opioid tolerance that may have changed, you know, after being off these opioids. So I'm going to turn it back over to Maureen, who's going to finish the case and talk about what do we do when ready to discharge this person.
Okay, so back to the case. One of the things I want to point out is that patients who are in treatment with methadone or in buprenorphine treatment, or patients who are using heroin, have an increased sensitivity to pain. This has been studied in the lab, and they've found that these patients have increased pain sensitivity, and they have reduced tolerance for pain. So that's something to really keep in mind when we see this clinically. So what happened to this gentleman then is the way we managed him is we got in touch with the methadone clinic and we got their approval and their cooperation, and we increased his methadone dosing in the hospital to 160 milligrams a day. And we divided it into every 6-hour dosing so that he would get the analgesic benefit of the methadone that we were using. We also did a number of different peripheral nerve catheters and had peripheral nerve local anesthetic infusions to be able to manage the pain in his leg. He was on acetaminophen every 6 hours. He was on ketorolac every 6 hours for several days, and then we switched him over to celecoxib. We gave him an IV PCA with hydromorphone in it, and hold on to your hats, he was using in the range of 40 to 50 milligrams a day of IV hydromorphone, along with the other medications we were using. We had him on a ketamine IV infusion of 7 mics per kilo per minute, and that was a continuous infusion. We had clonidine at 0.2 milligrams every 12 hours. We had him on clonazepam, ranging from 0.5 to 1 milligram every 8 hours. He was on gabapentin, which didn't really do much for him, and we switched him over to pregabalin at 300 milligrams a day. He was on duloxetine, 30 milligrams every day, and we had him on some muscle relaxants. And as far as non-pharm, we don't have a huge amount of non-pharm interventions available to us, but he was seen by the musical therapist 3 times a week, and he did have a TENS unit, and fortunately, psych was working along with us to be able to co-manage his anxiety. So as far as pain management is concerned, as Kathleen said, we have to be very concerned about the risks for relapse. That's a major concern for your patient as well as your patient's caregivers as you're approaching the point of discharge. So that really needs to be discussed very openly. The risks for relapse increase if there's exposure to medications that they were using on the outside, but the risk also increases if their pain is not appropriately relieved, if their anxiety and their depression are not appropriately treated, and if they lack support. So we have an obligation to work with the entire healthcare team to assure as smooth and safe a transition to the next place as possible. It's really important to have that open attitude and be forthright in providing education and providing support and reassurance. And we really need to enlist that patient in the plan for discharge so that we can do the best we can with assuring that they have success. Tapping into clinical and community resources, partnering with your social workers to assure a safe discharge is key. So optimally, the goal is going to be to wean, can we go back a slide, please? I'm sorry. The goal optimally is going to wean them off the opioids, if at all possible, prior to discharge. But that's not always possible. So in some cases, you're going the patient home and back over to the methadone maintenance program, and you need to have that conversation with them to let them know what's been going on. If they've been on buprenorphine and it was discontinued, they may need to go into a mild withdrawal while still in the hospital so that they can start when they leave, or you may find yourself sending them out with a small supply of an opioid with co-management with that buprenorphine prescriber, who will then assist the patient to go into the mild withdrawal and transition back over to the buprenorphine. And if they had been on naltrexone and naltrexone is still active, then they will follow up with their naltrexone prescriber. Patients certainly will need to be counseled about the next place where they need to be going. Next slide, please. If their pain requires that they continue on opioids after discharge, you may need to really work toward getting them an alternative level of care. One of the things that we often have to do is try to find a subacute placement so that their pain can be managed, they can participate in rehab, and they can gradually be weaned off of the opioids. If available in your community, tap into your addiction specialists who will help do the co-management of your patient upon discharge. Consider the use of those opioids, although there is no long-term evidence yet available to show that that is really going to make a difference. But we would like to think that the new products that are coming out with the abuse deterrent formulations will be helpful. And of course, continuing that use of multimodal analgesia along the way. If the patient no longer needs the opioid, and you can continue whatever non-opioid approach, medication-assisted therapy, but continue the other multimodal agents. So from there, I'm going to turn it back and open up the question period.
Great. Thank you so much, both of you. Is really, as I'm sitting here listening, it's an incredibly complex situation. It sounds like you guys really have it down on how to do this, and we certainly appreciate your expertise. We have been getting questions chatted in throughout the course of the presentation. We'll start on those in a moment, but just a reminder to anybody, if you do have questions, please go to the chat box and chat them in now, and we will relay them to our presenters. So we're going to start now with the first question, and I'll turn it over to my colleague Tiffany.
So the first question comes from Talia. Talia is asking, for patients with chronic headaches and are opioid tolerant, will this Tylenol NSAID combo put the patient at risk for rebound?
I think that one's coming to me. So this is Maureen. Complex headaches are really a challenge, no question. And if they've been on chronic opioid therapy, the chronic opioids themselves may very well be playing into the headache condition as well. And yes, there are the concerns about rebound. So you're going to need to work with that patient to do medication holidays along the way and use a multimodal approach. Try some of the other agents. And there are different ways to be able to manage headache that are well beyond what we really get into right now. But maybe that would be a topic for another conference at some point.
All right, thanks so much. The next question comes from Catherine. Catherine is asking that she was taught that antipyretics should not be given before or after immunizations, as they can interfere with the immunizations' effectiveness. She realizes that it's not on topic, but she was asking if you had any suggestions or input.
I'm going to have to defer to Maureen on this one because that's something that's totally out of my practice.
Right, so I wasn't speaking about the use of acetaminophen pre. I was talking about it afterwards, how you will find, parents using it to control discomfort afterwards. So, again, not something that I am going to say that I'm proficient in, but just that it's something that you will often hear in practice.
Alrighty. The next question comes from Regina. Regina is asking, how do you wean an oral post-op opioid patient prior to discharge after an elective surgery if they're being discharged in 48 hours?
This is Kathleen. So, if it was that small of a surgery that they're being discharged within 48 hours, the hope is if they already were on medication-assisted treatment before they came in, that they're going to go back onto that medication-assisted treatment. And if you have to use, I think this is what Maureen and I were talking about. So what happens when we have to get patients out of the hospital quickly and they may still have pain management needs? And I think this is when we're going to have to pair with the people in your community, whether it is the primary care, whether it's an addiction specialist. What may happen with patients that are discharged from the hospital here, they're going to have an appointment with me within like 2 or 3 days. But you're really going to rely on your multimodal analgesia. And in cases like if someone's on buprenorphine, like I had a patient that had the same day and had a lumpectomy with an axillary node dissection and had regional anesthesia, and we used multimodal analgesia, and we just increased her buprenorphine for a couple of days. But that, if it's going to be that short of a surgery, you're going to need to actually pair with your community provider for that.
Thanks for that. And, as a primary care provider myself and wondering about community-based options for referrals once you are post-op, if you can maybe finding addiction specialists or people to partner with in the community and some of your recommendations on those that you partner with now.
Hi, this is Maureen. I think I'd just like to make a point too, as far as that's concerned. The fact that we now as nurse practitioners have the ability to be able to prescribe buprenorphine really calls upon us to take that step and get ourselves licensed to do so, because we know that there are many patients, and I live right outside of the New York City area, we still struggle with trying to find prescribers, and this is a big need for our patients, and it's really a wonderful way to be able to assist them. So I would put the plug in there that many of us should be getting ourselves able to prescribe buprenorphine.
And I think to your point about like what happens, how do we do community resources? I mean, I'm in rural New Hampshire, so I have other than referring to primary care providers within our organization, this is where we have to partner with those primary care providers to guide them. Okay, this person had this surgery. They really should be off opioids completely within X amount of days. You know, I'm going to give them X amount of days worth, but then I'm referring it back to you. But if it's someone who's had active opioid use disorder, it's like Maureen said, you know, where are the people in our communities that is this the opportunity that that person may be able to start medication-assisted treatment? And where I am, it's much more difficult to get people onto methadone maintenance because some of my patients might have to drive an hour and 40 minutes each way to get to an opioid treatment program. So that's where the call comes to increased use of medication-assisted treatment with buprenorphine in the primary care provider setting.
Great. Thanks for those. And I would also encourage anyone on the call to be active in both your state and local nurse practitioner organizations. If you're not a member of the AANP, they have regional groups as well that can help you navigate some of these issues. So those are some additional resources.
The next question comes from Maristella, and it's actually pretty well timed given our conversation. Maristella is asking, what are the qualifications needed to prescribe buprenorphine, and is this medication widely available in an acute care setting? She asks because it is not a part of her organization's formulary.
Okay, so the thing is that as nurse practitioners, any nurse practitioner, after completing 24 hours of education that's widely available for free through AANP, who partners with ASAM, the Addiction Society of you can complete it all online. I actually did it myself back in February, March, and you are then able to prescribe buprenorphine for medication-assisted treatment. You have a maximum of 30 patients a year that you can do that with. But you don't have to be a pain specialist. I mean, the whole point of using medication-assisted treatment with buprenorphine is to try to put it in the hands of primary care providers. As far as in the hospital setting, any hospital should be able to, if you have a patient that comes in on medication-assisted treatment with buprenorphine, it should be able to be continued when they come in the hospital, because you may have patients that are admitted that aren't admitted for a pain crisis, but they're on buprenorphine. So I would say that you really need to talk with your pharmacy and find out, why isn't it on the formulary? As far as starting it in the hospital, that's where it becomes a little more challenging, because you have to make sure that you have someone, like if someone's on buprenorphine, like if I have a patient on buprenorphine, once they're admitted, just like methadone, any prescriber in the inpatient setting can continue the methadone or continue the buprenorphine. But in order to continue it after discharge, it has to be with either an opioid treatment program, which is federally funded in the case of methadone, or to someone who is waivered to prescribe buprenorphine, where after you're waivered, you get a special X before your DEA number.
All right, thanks so much. The next question comes from Karen. Karen is asking, would you recommend using Opioid instead of a PO Tylenol for this opioid tolerant population?
Okay, so Opioid is the brand name for intravenous acetaminophen, and it is often used for the management of acute postoperative pain. You will find that due to cost issues, most organizations, as far as formulary is concerned, most of the organizations that have it are going to restrict you to a certain length of time, because depending on your contract, it may run around $100, $120 a day. There have not been head-to-head studies looking at analgesia between IV acetaminophen compared to oral. We generally use it in the immediate acute postoperative phase. We use it for patients who are not able to take oral acetaminophen, And then once they are able to take oral, we switch them over to a gram every 6 hours of oral.
Okay. This next question again comes from Regina. Regina is asking or stating that many insurance companies won't cover the costs of celecoxib unless the patients have failed other less expensive NSAIDs. How can she get how can I word the pre-authorization to ensure approval?
This is Kathleen. I think in the case that we were really putting up is really where using it in the perioperative setting, so using it preoperatively, and that's where we were really looking at the use of non-steroidals is in that setting. So if you're in the inpatient setting, it shouldn't be a problem. When we're looking at it in the ambulatory setting, if you're looking at using it chronically, then you're going to have to look at what are the risk factors. You know, does this person have a history of a GI bleed? Are they at more risk for a GI bleed? You're going to have to go through, you know, so it's not necessarily failing efficacy, but looking at what are the risk factors for potential gastrointestinal bleed that requires you to consider using celecoxib. But the other option is, you know, meloxicam has a lot of COX-2 properties, and sometimes it's easier to obtain than celecoxib.
Okay. Next question comes from Matt. Matt is asking if either Kathleen or Maureen have any thoughts on Project ECHO coming out of New Mexico for supporting the sharing of best practices surrounding SUD treatment. Matt believes that NH is trying to start one up, and if there are any lessons or insights that would be helpful.
Where did I go?
Just one point of clarification on that one as well. Project ECHO is was started in New Mexico. It was a group of specialists working in hepatitis C care, where they did their grand rounds via, you know, teleconferencing, and also moved it to patient management in the same format, one-on-one with providers, to help them through some of the more the management of complicated patients. And I guess wondering if that's a format, maybe you don't know about it or you may not know, but it is something that's out there currently, ECHO, Project ECHO. You can Google it and find out more about them, either if it's something you've heard of or something you know of like that, or maybe just your thoughts on that as a way to be able to educate clinicians across the country on the use of buprenorphine.
Yes, so yeah, I mean, and I think that I'm actually looking it up as you're doing and looking at telehealth. I think that the more widespread education about buprenorphine in general needs to be done. Like I said, I'm in rural New Hampshire, and we don't have opioid treatment programs with methadone, and so I mean it's much more difficult unless you're in our quote-unquote bigger cities. And so I think it's my take-home point that I brought up earlier is that as nurse practitioners, we have the option to try to change things, because I think that, you know, we are the ones sometimes that are taking care of the more underserved population and focused in primary care. And I think that that's where I think we're going to get the biggest change, is more and more nurse practitioners becoming competent in this, and especially, you know, becoming waivered to treat people in their primary care settings.
Great, thank you for that. We're going to move to our next slide here, and just some information. We're going to take one last question, but I wanted to put up this next slide just to show you that where to get in touch with us in case you have questions after the webinar is over. The link at the bottom will take you to information about MACRA and TCPI and how it may affect you. I would highly encourage you to go there and take a look at that. Before we finish this out, we have one last question, and we do have too many questions to be able to answer at this time, but for everybody participating, just so you know, we will forward the questions to our presenters after the presentation, and we will be getting back to you with their answers. But for our last question, Tiffany?
Sure. And we're going to have the last question come from Mary, and it's just a short question. And she's asking with regards to ketamine infusion treatments, and does the patient require an ICU setting for these ketamine infusion treatments?
Oh, that's a really interesting question, and it really is going to depend on the state that you're working in. We had been using ketamine long before the state had recognized that we were using it for pain management, so we were using it quite safely on the floors and really had no issue. But when the state Board of Nursing reviewed it, they then put forth a paper requiring that patients be more closely monitored for the first 24 hours of ketamine therapy. So patients are placed in an intermediate care setting, and if they can be safely managed on the floor in 24 hours, they leave that intermediate care area, unless, of course, they have other issues that would require an ICU stay. But you will have to check with your state board of nursing to see what their policies are, their recommendations are.
And I can tell you in New Hampshire, we're still battling the fact that they have to be in a monitored setting unless they are palliative care or toward end of life. So again, but it really just depends on where you work and where you practice.
Great.
I would just add, it's kind of amazing because you can have opioids at most incredible doses out on the floor. And we know about the respiratory depressant effect, and yet ketamine is opioid sparing. So it is interesting. We have a ways to go here.
Yes, we certainly do. I just want to close out by thanking you both so much. This is really very timely information. Really do appreciate your expertise and having the availability of a larger audience to get the word out, which I hope people will follow up on that and get certified for buprenorphine. For those of you that are interested, again, in our next Lunch and Learn, it's listed here. We'll be doing part 2 of a series that we started back in the fall on EHR implementation for small and rural practices. We do offer the Lunch and Learns monthly, so we hope everyone has enjoyed today's Lunch and Learn, and I'm going to close it out today by saying thank you to our presenters and to everyone that was on the call, and we will be following up with getting answers to your questions. Thank you again.
Thank you so much. Bye-bye now.
Bye-bye.